And thank you, Dr. Matthew, for inviting me for this very well crafted, beautiful program. All the topics are excellently well thought out. And thank you for giving me this particular topic, which is actually really a very holistic view of diabetes. On the other side, I feel that we don't really, death is a very philosophical and spiritual topic. Actually, we can't really dictate when somebody is going to die. Probably patients live because of us or despite us. I really don't know, but we have to keep trying. With that little, with those little remarks, I shall start sharing my screen. Right. So the topic here is how can we reduce deaths in people with diabetes? If we want to know how to reduce deaths, although we know it, let's just have a look at. I do not have any disclosures. Let's have a look at what is the average life expectancy of a 50-year-old individual with diabetes. Well, there is evidence to say that it is 6 years shorter than it would be without diabetes. So there is a real threat that diabetes can really reduce life expectancy. But can we do something about this? I'm going to talk to you a little later about this, but I can't resist putting this here, that these very 6 years of reduced life expectancy that we talk about, well, you can increase it by 7.9 years. That's what the Steno 2 says at the end of 21 years. So this Steno 2 happened a long time back, but if you look at it now, 21 years later, just a few years ago, it was published that the median survival time was increased by 7.9 years. So what does this mean? This means that death is not inevitable. We can increase survival. We can increase the life expectancy. But before that, what are the main causes of death? Well, this is a slide that is really old, but still holds true today. In 1995, it was that the percentages of deaths with ischemic heart disease and other heart disease were the chunk of the cause of death in type 2 diabetes, as you can see here. Then you can also see here that mortality in people with diabetes, and diabetes is listed as a cause. You can see the third cause in the graph, which means to say that blood sugar itself, which means HbA1c itself can be a cause of death. Then you have cancer, stroke, which again goes into cardiovascular disease, infection, and other causes. Then there are certain other causes which have not been mentioned in this particular slide, and that is CKD. Today we talk a lot about CKD deaths, so that is another thing that we are going to focus on. Then of course you have the acute complications causing death, which actually comes under others. And the last thing which I would like to say is that if there is lack of medication, which is there in our country a lot, you saw a very beautiful lecture by Dr. Sanjay Kalra where he talked about out-of-pocket expenses, insurance not covering so many things. So lack of medication, lack of medical help in certain areas. So these are all the causes of death. So let's now focus on the scientific causes, that is the cardiovascular disease, etc., and go one by one. In diabetes, we know that you have microvascular disease, macrovascular disease, your UKPDS, DCCT, all these studies showed you that perhaps these two are completely separate entities. That means macrovascular may be completely different from microvascular disease. And traditionally, what have we been taught? Now, this is a paper that was presented at the ADA 2020, where it says that for macrovascular disease, be it coronary syndrome, stroke, or whatever, and also for heart failure with reduced ejection fraction, perhaps life-saving would be statins and antiplatelets. Whereas microvascular disease and also for heart failure with preserved ejection fraction, perhaps HbA1c and tight glucose control is perhaps more important. So these are a few issues which you must remember when you're talking about death in diabetes. So what's the issue number one? Issue number one is HbA1c, and that is diabetes itself. So what has that got to do with mortality, and what has that got to do with cardiovascular disease? So you can see here now that there is a clinical perspective. This is a study which has come out very recently last year. So is it any different actually from the previous? And you can see here, there was a national cohort of US adults, and diabetes was associated with 16% increase in all cause and 18% increase in cardiovascular mortality. And the second point is very important, and that is Among those with diabetes, an A1C of 6 to 6.9 was associated with lowest mortality, irrespective of age or prior cardiovascular disease. So statistically, they could delineate that whatever age you are at, whatever is the cardiovascular disease status, if your A1C is between 6 to 6.9%, you had the lowest risk of dying. And diabetes mellitus related excess mortality, which was there, it is lower than in the studies found in the past. So clinically, what does this mean to us? Clinically, this means to us that an A1C of 6 to 6.9 is associated with lowest mortality, and that is something that we should attempt by all means, and this is going to be one of the causes of reduction of death in diabetes. So as you can see here, this is the same thing trying to tell you in the same study. You look at both all-cause mortality and you look at cardiovascular mortality, and you can see that whether there was prior CVD or no prior CVD, as you can see, as the A1C goes above 6.9, the deaths keep on increasing, whether it is all-cause or cardiovascular. So A1C is very important for both all-cause mortality and cardiovascular mortality, and it is not just for microvascular disease. It is also important for all-cause mortality. In the same way, if you look at age, for example, it does not matter whether you are less than 65 or more than 65, both all-cause mortality and cardiovascular mortality go on increasing as A1C increases above 6.9%. So definitely a good A1C target is going to reduce deaths, as you can see, and this is a very recent paper. The next big issue, of course, is cardiovascular disease. And here we know this is all very well known to you. The stroke risk, the coronary artery diseases, everything is increased in cardiovascular disease in diabetes. So what do we do for that? For that, we have certain drugs. Of course, treating heart disease separately is fine. But the drugs that we use for diabetes, today we have overwhelming evidence. This is a meta-analysis which shows you that the time to first MACE and time to first hospitalization for heart failure, everything is in favor of SGLT2 inhibitors. As you can see, other than the ertugliflozin, all the other have shown you in this forest plot that whether it is EMPA-REG, Canvas program, Declare-TIMI, Credence, all of them show you that SGLT2 inhibitor can prevent cardiovascular death and also heart failure. Again, this is a systematic review and meta-analysis of the same thing, which is very, very new. It has come out in 2020, and this is the forest plot for that, whether it is primary prevention or whether it is secondary prevention, whether it is MACE, cardiovascular death, MI, stroke, CV death, all-cause mortality, almost in all of them. Of course, the overwhelming evidence is for heart failure, but even for the others, you can see that SGLT2 inhibitors can prevent death because they can prevent all-cause mortality and cardiovascular mortality. And you can see in this slide, the hazards ratio are very well depicted. And whatever is, whichever SGLT2 inhibitor you are using, other than, of course, ertugliflozin, as I've already told you, CV deaths are reduced. The hazards ratio are very, very impressive. Heart failure data is very, very impressive. So this is one drug class that can actually help you to reduce deaths in your patient, and it is worth thinking about. Now, this is the second group of drugs which can help us to reduce deaths, and that is GLP-1 receptor agonists. And you can see here that the various studies which are there in all the CVOT trials, many of them are neutral, but you can look at the leader study, the second one from top, and you can see here that it can actually reduce deaths. The relative risk reduction is quite impressive, almost 20%, and the confidence interval is very, very significant in this, as you can see. So the leader study tells us that, and that is why there is a label today for use of these particular drugs. So the newest one that has come, that is oral semaglutide, this also has shown very promising results in cardiovascular outcomes in this particular population. So you can see that composite primary outcome is also very good. It is very good for non-inferiority, and there is a hint for superiority, although it is not statistical, the p-value is not statistically significant. As far as non-fatal stroke is concerned, there's not much. But as far as death from cardiovascular causes, everything is looking, at least it is going towards a trend towards helping patients to overcome cardiovascular disease. Let's come to issue number 3, and that is chronic kidney disease. For the last 20 years, we had ACE and ARB, which we are still using, and which is still very useful in reduction of deaths or progression of chronic kidney disease and end-stage renal disease. But now we have this new class of drugs. After 20 years, we have something that can slow the progression or even prevent kidney disease. And for that, again, you have the SGLT2 inhibitors. And you can see this latest meta-analysis, and it is so much to the left that the renal composite was very, very favorably affected by almost all of them in the same manner. So you have another drug now, which after the ACE ARB, which helps you to reduce deaths or at least progression of renal disease. And as you can see here, the overall the SGLT2 inhibitors were found to be renoprotective and reduce the composite of worsening of renal function, end-stage kidney disease, or even renal death. So again, death was very much a part of all of this. Credence, the newest one, the best one, because it was meant to look for renal. The others were actually CVOT trials, but this one was particularly so I'm just showing you a prototype, and the EGFR decline. So 60% reduction in yearly loss of EGFR is what you can see here. So this is the latest guideline in 2019 because of the overwhelming evidence of SGLT2 inhibitors and of GLP-1 receptor agonists. It is said that these must be considered if you think that somebody has got CVD risk factors. Now I bring your attention to a very small study called the STENO2, which was multifactorial intervention. Till now I've talked about renal protection, I've talked about cardiac protection, but actually it is not so. It is multifactorial. So it was actually a small study. Participants were randomized in 1993 to intensive. There were just very few patients in this. 4-year follow-up was done for microvascular outcomes. 8-year follow-up was done for macrovascular outcomes, and then the randomization was ended and everybody went into intensive care and the observational part began. And in 2006, that is 13 years from the beginning, they did the outcomes. And then in 2014, post-trial 21-year outcomes. It was a simple single center study. Hardly 160 participants were there with metabolic syndrome, type 2 diabetes and microalbuminuria, as I have mentioned to you. And I'm going to tell you only the 13-year and 21-year data because we are interested in mortality. After 5.5 years of observational follow-up, which means 30 years when it actually started, the primary endpoint of death from any cause occurred in 30% in intensive group compared with 50% in conventional, which was an absolute risk reduction of 20%, which was very significant. And also for CV events, it was 29%. And at 21 years, again, you found the same. And this is my important slide, where the median survival time was increased by 7.9 years. So this is very, very important that simply doing multifactorial intervention, they could find that the median survival time was increased by 8 years. So it is very optimistic that if you fire on all cylinders and look at everything, you can increase survival in type 2 diabetes. And these are the different targets that are used. So you can see here that lifestyle is used, ACE-ARB is used, aspirin is used, then the hyperglycemia is reduced. For dyslipidemia, statins and fibrates are used, hypertension is looked at. So it's a multi-pronged approach, and that is what we follow today. So the STENO2 diabetes was in that sense a landmark and a seminal study. Issue number 4 is statins. Well, this is the EAS, EASC last year's recommendations, and they say that you must attempt LDL reduction. You have different guidelines here. If they're at very high risk, you reduce 50% from baseline. If they are at high risk and LDL reduction of more than 50% and an LDL goal of less than 70, and you have to intensify it based on your results. And this is the ACC and AHA guidelines. Please look at this. Diabetes mellitus age 40 to 75, you must give moderate intensity statin to all. And if you do the risk assessment in this fashion, then you might have to give intense therapy. But look at this. ASCVD risk enhancers. That means you look at ethnicity, and we are of South Asian ancestry, so it puts us at very high risk. So statins are a must, and you should follow the guidelines. Blood pressure, very important. It should not be forgotten. This is the latest ADA guideline, and you must initiate therapy at the appropriate time, and you must see that the BP is down. Aspirin, well, aspirin is used for primary prevention. You have to discuss with the patient. It is not very sure whether you can use or not, although for secondary prevention, of course, it is used. My last bit is issue number 6, and that is prevention to reversal. If you look at prevention, this is the 22-year follow-up of diabetes prevention study. 75% enrolled patients who were still alive. So you have to lower the risk of early changes in eye disease, kidney disease, and disease endpoints. And this is the famous direct trial which tells you that you can actually reverse diabetes. If you reverse diabetes, of course, you are going to reverse cardiovascular disease also. This is my own data, the impact of a very low calorie diet on reversal of metabolic disorders among Indian subjects, a stage definite regression. This was accepted for presentation at the ACE 2020 this year, and this is my own data. So this is my last slide. As you can see here, you have to have multiple targets. If you have multiple targets and you treat to target, definitely you can reduce death and increase lifespan in your type 2 diabetic patients. Thank you.